Welcome everyone to this repeat tutorial, our first tutorial on the Cath Lab series of lectures, the CCL lectures, entitled Coronary Angiography and Coronary Angulations. My name is John Boland. This tutorial is intended to replace the live tutorial I gave last night. I was displeased with how it went. I think I tried to convey too much information and I considered that it ended confusing some of you rather than teaching you. So this one is more streamlined. It'll be shorter, sharper, more focused on your needs, and I think you will learn more from it. Our learning objectives, which I have now defined, are to understand the terminology. There's a lot of new terminology here. Understand the function of the X-ray gantry in the cath lab. We will review our coronary and cardiac angulations for X-ray images. You will learn to recognize your various cardiac orientations. We'll also review coronary angiography so that you can identify the different coronary arteries, the right coronary and the circumflex and their side branches. This is meant to cover lectures 1 to 6 of this week. However, lectures 1 to 4 cover mainly anatomy, cardiac anatomy, general anatomy that I'm sure you're well trained on, that were intended more as a revision, and an introduction to the cardiac work you're going to be doing, particularly in your roles as echo techs. But as echo techs, you will at times work in the cath lab very closely with the cardiologist in relation to these X-ray images. Have a look at this first image on the left. It's a standard ventriculogram that you've seen before, backbone on the left-hand side, and we see the heart in profile. We'll have a look at the next slide. And this shows you how the gantry rotates around the patient. The patient lies on a table, and the gantry can be roof-mounted or floor-mounted, but it has a series of knuckles and axles, so that this C-arm or U-arm rotates around the patient in that direction. Laterally, it can also rotate longitudinally along the length of the patient towards the feet or towards the head. Right now, it's in the AP position, anterior-posterior, although remember, the radiologists refer to the reverse. They refer to the image from the source. They call this posterior anterior. And cardiologists tend to abbreviate it, so we just call it the anterior view. Just be aware of the differences in terminology when you read different papers from different journals. When we view the heart from X-ray images at different angles, it's an analogy to looking at a car from different angles. The first picture on the left shows the car end on. Imagine looking at the heart end on from apex to base, as opposed to looking at the heart or the car in profile. You'll get totally different images. And then you have different angles looked at from the sides and in the heart from above and below, anteriorly and posteriorly as well. It's our job to build up a three-dimensional image of the heart from images comparable to these of this car. We start off in the AP, as I've said before. A patient lies on the table. You have an X-ray source below the patient. X-rays go through the patient and are picked up by a detector or an image intensifier or a camera, whatever term appeals to you most. And this is the AP, anterior-posterior projection from the cardiologist's point of view. The X-ray machine, the gantry, rotates around the patient so that the detector and the source stay aligned, whether the gantry moves to the left or to the right of the patient. When you move to the patient's right side, it's called the RAO, right anterior oblique view. When the detector moves to the left side of the patient, it's called the left anterior oblique view, LAO. We take our direction, our lateral angulations from the position of the detector. So remember though, the camera rotates not just laterally, but also longitudinally from the head to the feet. Think of the detector as a camera picking up the shadow images from the source as an X-ray. It'll become clearer as we move on. These are our cordiocranial angulations. Remember, the lateral angulations rotate side to side laterally around the patient, whereas these caudocranial angulations move cranially or caudally towards the patient's feet, and again in reverse direction to that of the radiologists. So cardiologists call this caudal, and cardiologists call that cranial. It's the reverse with the radiologists. Let's have a look at a moving ventriculogram. This is what our game is all about, looking at moving images. And here we have a ventriculogram, the same image as on the first slide, showing you the catheter inside the left ventricle injecting dye, showing the heart pumping evenly from every direction, a normal cardiac contraction, the dye cleared very quickly down the aorta. In this view, what I call the cardiac profile, the left ventriculogram in profile, you see the backbone is on the patient's right and the ribs slowed down to the patient's left. And we see the heart in that elongated profile, what I call the profile. That view is in contrast to this one, which is in the opposite direction. This is in a straight LAO, which means it's on the left side of the patient. The ventriculogram that you just saw was on the patient's right, straight RAO. So you're looking at it from a totally different side, and we're looking at the heart end to end, from apex to base. Have a look at this. The catheter is in the aorta. This is for an aortogram, and you can see a little bit of dye leaks through a tiny little leak in the aortic valve, so you can just make out the concentric view of the ventricle, the left ventricle. You're looking at the ventricle from top to bottom. You can just make out the coronary arteries filling from the left and right coronary sinuses. And the dye is cleared straight down the aorta, and you can make out valve movement. At the back of your mind, try to compare these images to what you might see on echo, although they're totally different, but they are related. Remember those two views, straight LAO in this case, heart end to end, straight RAO, the ventriculogram view, the heart in profile. These are the same images I just showed you in the previous slide. Compare them to this, which shows you the nomenclature of ventricular segmentation. This view is slightly different from the standard LAO of the heart. This one is rotated so that the camera is more cranial. You will rarely see this view. I have rarely seen it except in special circumstances, but it illustrates the nomenclature. Number one is basal in both sides. This is the basal aspect, that's the apical aspect. And in this view, that is the lateral aspect, and that is the septal aspect. Going to the RAO, the heart in profile, this is the anterior basal, and that's the inferior basal. That's the apex of the heart, the apical portion. This is the anterior wall, and that's the inferior wall. This is the part supplied by the right coronary. That's the part supplied by the left anterior descending, the LAD. We'll learn more about that as we move on. Drawings are excellent, but they're flat and they're meant to represent three-dimensional structures. I think you can visualize this as a cone of some sort with a plane of cross-section coming out of the page in that direction. The circumflex branches align with the posterolateral branches of the right coronary, and you can imagine another plane of cross-section coming out of the page towards us slightly, lining up the LAD with the posterior descending artery of the right coronary artery. That's just to put it in 3D perspective. You'll learn the names of the coronaries as we move on. This is the equivalent of an AP view of a patient lying down. In the RAO view, the heart in profile, the LAD goes across the anterior wall, but it sort of deviates slightly. The right coronary artery is simpler. It's one big fat juicy vessel feeding the bottom of the heart, but it branches. It bifurcates into the posterior descending artery in the bottom and the posterolateral artery going higher up. Again, this will become clearer as we move on, and you will learn how to identify these. This has another artery called the ramus intermediate. It's another marginal branch, but it arises right in between the LAD and the circumflex. If it arises from the circumflex, it would be just another marginal branch. And you notice these branches, marginal branches, come off the circumflex. Septal and diagonal branches come off the LAD. And they're just numbered, first, second, and third diagonal, first, second, and third marginal, and first, second, and third septal. You need to become familiar with the coronary anatomy, but more importantly, learn how to identify them in our X-ray images. This is a nice way to illustrate that 3D structure in a flat plane. These views are all in the LAO, the aortogram view, And in this one, in a straight LAO, you're looking at the heart end to end. Think of a football, a rugby football with the LED along the seam coming out of the screen towards you, as opposed to the RAO, where the rugby football is on its side, and that is the seam, the LED coming down here. And the cranial view is looking at the heart from higher up. You can see how this has a curve, this is more straight, and it's separating these proximal vessels. That is the LAO cranial view. You will see that again. And a funny view is the caudal view, LAO caudal, which effectively looks at the heart upside down. We'll leave that one for the moment. But the RAO views are easy to pick because the heart is mainly in that profile. And the orientations, both in the LAO and the RAO, are cranial and caudal, tilting towards the head and tilting towards the feet. We'll move on. These are real views. We'll start with the right coronary artery because it is a simpler vessel. Start with the LAO. Again, that elongated view of the heart end to end, the football coming out of the screen towards us, and the right coronary artery wraps around the lateral edge of that football. So it appears as a C shape. And that is what's called the traditional LAO view with a C shape. And towards the bottom, the inferior aspect, the vessel bifurcates into the posterolateral, going upwards here, and downwards, the posterior descending. Downwards D, descending D. The posterolateral actually tends to go into the heart rather than just up and across. To me, they all look like C's of varying shape, but this is what people refer to as the traditional C shape. The second view, let's look at the opposite side, is the RAO. Now, the straight RAO is that ventriculogram view where the heart is in profile, and the artery, the right coronary artery, curves and flattens out along the inferior wall. And here, because of that lateral view, the profile of the heart, these two vessels tend to overlap. When vessels overlap, we separate them with either caudal or cranial angulation. So here you're in the left, looking at the heart end to end. Here you're in the right, the RAO. Remember, this is the patient's left and right. And the heart is in profile, like a ventriculogram. A view here is LAO cranial, where you're looking at the heart end to end, but you're rotating the camera towards the patient's head. And that cranial rotation, or cranial angulation more correctly, separates the PDA and the PTL, PDA going down, PTL going apparently upwards, so we can see better any lesions in there. These are only three views, and they're the most common standard views for the right coronary artery. I think you should be able to remember them or memorize them. That's the easiest way. However, the C shape with the heart end to end should be straightforward. You can imagine it. The RAO in profile, the vessels overlapping in that inferior aspect, and the LAO cranial tilt separates the two bottom ones. It's a matter of getting used to them more than anything. We'll move on and have a look at several different views in different patients. LAO straight here, LAO cranial here, and the RAO straight as before. Look at the RAO straight one, the profile. You can see those vessels overlap going along the inferior wall, anterior, inferior. However, you can't just memorize all this because vessels have different shapes in different people. This vessel has very tiny distal vessels, this right coronary artery. This would be a non-dominant right coronary. Normally, the left and the right coronaries are equally balanced, but you can have an imbalance, such as the left circumflex can dominate, or the right coronary can dominate. Going back to the LAO, notice they always have a little bit of angulation in the other rotation because they're not going to be perfect every time. They're not going to worry about those extra seconds. And that tends to make our lives a little bit harder because look at this. LAO 12, cranial 29, LAO 20, cranial 33. They will be different. But going back to the straight LAO, that's C shape that people seem to like. And you're looking at the heart end to end. In the straight LAO, the backbone is on the right. However, they can magnify the image and center it, so the backbone is not that clear. In the straight RAO, once again, the backbone is on the left, the opposite side of the detector, and depending on the orientation and the angulation and the magnification, you may not always see it. So don't depend on that as too much of a guide. Here, it's sort of in the middle. But The main thing about the LAO, this view with cranial tilt, is it separates the bifurcation of the PDL and the PDA. And notice this has a very high takeoff. That's the right coronary artery. Let's have a look at the left coronary artery, which is more difficult because it's a more complex vessel. And we take more views. We take 5, 6, sometimes 7 views as opposed to those 3 views in the right coronary artery. I'm comfortable with my explanation of the right coronary artery. I'm comfortable you should have followed that. Let's see how we go with the left coronary. One view you just have to memorize is an LAO caudal. Imagine the detector at the patient's feet in the left-hand side of the patient. And this looks like a football standing end to end, coming out of the screen towards us. And in this view, there's the left coronary artery going down that seam, and the circumflex comes across. This is the LAO caudal. Look at the LAO cranial. The football is still standing on its head, but it's rotated laterally completely. This is the LAD. How do I know? The LAD has these branches coming off it, the septal perforators and the diagonals. You can't really see them there, but by changing views you can identify them. In this view, we're now looking at the RAO views, and this is an RAO caudal. You can see the LAD coming sort of out of the screen towards us with the septal perforators there and the circumflex wrapping around the side. It's almost like that ventriculogram view, but this has caudal angulation, so it's not a true ventriculogram view as compared to this one. This is the true ventriculogram view. Remember the ventricle, the heart in profile. The LAD goes along the upper margin, the anterior surface, and it sends off those septal perforators, usually at right angles, and diagonal branches. They all overlap because you're looking at a flat plane of a 3D image. And this is the circumflex. Not the right. We only inject one vessel at a time, the circumflex wrapping around that aspect of the heart. So in these views in the RAO, you should always see the circumflex and the LAD. The circumflex has the marginal branches. The LAD has the septals and the diagonals. They are clearer in some patients than others. Right now, just know there are different views, and different views show different aspects of that coronary anatomy. Not all shots are good. This would be a very difficult one, but sometimes that's all we have. In this case, that is the LAD. It's a different angle. They're all different angles. And the LAD, if you saw it in a bigger image and a moving image, you might see the septal perforators coming off it and the diagonals going off to the right. And this is missing a circumflex, either because the injection is poor, or it's occluded, or it's anatomically aberrant. This might clarify things. I will go through 3 of the major views for the left coronary artery for 6 different patients. This is the cranial view, which is to my mind the easiest because you don't have to memorize it. You can just look down at your chest, look towards your belly button, and then turn your head slightly. That is the cranial view. You can look at your heart. Strictly speaking, you're just looking down at your belly button, but your eyes have to focus on your heart. If you imagine you have a pencil in your shirt pocket over your heart, by looking at the heart slightly from your right, with your head tilted forward, that pencil will go slightly from the top left-hand corner to the bottom right, in a diagonal. That's the easiest way I can explain the cranial view. You can memorize it, but you can always check it by looking at your chest and imagining a pen there. You have to tilt your head fairly forward to get that angulation, otherwise the pen will appear straight. But that is the cranial angulation, a straight cranial view. You see the LAD with the septal perforators very nicely coming off, and the circumflex wrapping around to the side, and that is the left main. The left main is the branch off the aorta that gives rise to the LAD and the circumflex. Now this is a cranial view with a very slight RAO angulation. All of them do that. You're not likely to have too many that are perfectly zero. So these are representative of what you're going to see with a cranial angulation. Cranial, that pencil going diagonally across from top to bottom, left to right. I'm talking about the screen's left to right, not the patient's left to right. It's your view. You're looking at your own chest now. Left main, LAD. Now, and the circumflex. We'll just go through them all. Slightly different anatomy, slightly different contours, but this shows very nicely the LAD in every image. That's because cranial views are best for the LAD and the left main, whereas caudal views are better for the circumflex. All this should become clear onto you as we move on. Have a look at this one. In my ECG tutes, I mentioned the anteroseptal changes that are associated with ischemia and infarction. Look at this vessel. This LAD is almost occluded. That patient would have ST changes in his septal branches and his anterior branches, because if that vessel occludes, you're occluding all those septal perforators along with the main feeder artery to the anterior wall. So that's why infarcts are so common in the anteroseptal aspect. If that vessel, which is a septal, were to branch off on its own, then you would only have changes in V1 and V2, as opposed to V1 to V4. I hope that clarifies a little bit of your ECG. It's always good to keep these things in mind. Let's move on to a different view now. Remember this cranial. This is an LAO cranial, meaning your head is still tilted forward. The II, or the detector, is up towards your head, looking downwards at an angle, but it's also tilted to the left, LAO cranial, and that gives you that football shape that we saw before, standing on its head. The seam of the football is here. The seam of the football is there, the seam is there, the seam is there, the seam is there. Before, the LAD was going diagonal in the straight cranial. What we've done here is tilted the camera to the LAO, the patient's left. We've moved from the cranial to the LAO, so we've dragged that LAD across to the left. In the straight cranial, the LAD was diagonal, like that, top left to bottom right. The LAD is now much straighter and slightly to the left, more accentuated to the left in these two shots. And this is where you just need to identify your vessels. The LAD is long and straight, curving to the apex. That's a football coming out of the screen towards us a bit, but it's still in that elongated top to bottom view, standing on its head. So you will always have slightly different anatomical configurations, but you will learn these differences and they become much clearer when you see real films. Not long to go, we'll have a look at the other view. We've looked at the cranial, the LAO cranial. Let's have a look at the RAO cranial. Here you have rotated the detector to the patient's right, the RAO. I like to think of this view as the bunched up view, because in most cases the LAD and the circumflex will overlap. You can't really separate them, but it's still a cranial, and notice how beautifully it shows you the anterior portion and the middle portion of the LAD, right up here. And you can see the circumflex branches coming off it, but they're overlapping. They will all look slightly different. Look, here it's almost horizontal. There it's almost horizontal. Here it's more diagonal. But with time and experience, you learn to recognize the difference between that cranial and that LAO rotation. And there are other views that are a little more complicated, and that was my mistake in the live tutorial. I added them all in. All I want you to appreciate really is these basic views, plus one other, that spider view that I mentioned, which is the LAO caudal. We've seen the LAO cranial a moment ago. The LAO caudal, this is the typical view. It's called the spider view because imaginative cardiologists figured they could see a spider shape in here. Well, you can in some, particularly this one, maybe even that one and that one, and that one, starting to lose it in these two. But this is a view you just need to memorize because it is so unusual. And caudal views tend to look at the heart from below, and if you have a little model of the heart and you turn it upside down, that's what it looks like. Remember, the LAD is curving along the seam of that football down there. LAD is curving down that seam. LAD is partly occluded, but it's curving down there with the circumflex coming off this branch. LAD there and circumflex there. I know this will be the LAD and that's the circumflex. This one could be anything because we can't see too much of it. And we get used to that because it happens frequently. So there are four basic views that I think you should understand. They're not that complicated. The right coronary you should also remember fairly well. Let's have a look at those LAO cranial angulations against the straight cranial and the RAO cranial now in sequence. You can see that football shape standing on its head, the LAO cranial. You've shifted the detector to the left, to the patient's left. Cranial, you're looking straight up and down to your heart. A pencil lying along the line of your heart will have that slight angulation. It could be a little more vertical or a little more angled, depending on the patient and the extent of that cranial angulation. And the RAO cranial is still that same view, the LAD up the front, but the detector has moved to the patient's right. These three looked at together, I hope, clarify that rotational aspect and that cranial angulation that separates overlapping vessels. Don't worry too much though. You will gain much more experience when you see a few hundred of these live in a cath lab. Summary. We're nearing the end here now, so our summary slide is: remember, in the RAO, the patient's right, the heart is in profile. That's your ventriculogram view. That should be ingrained to you by now. In the LAO, the patient's left, the straight left, the heart is foreshortened, and you see that aortogram end to end. The cranial is best for LAD and diagonals, meaning the heart, including the LAD, is tilted downwards because the detector is looking at it from your head. The caudal is best for left main, left circumflex, and the obtuse marginals. And this, particularly in the LAO, shows you the heart from below. That takes a little getting used to, but if you see models, you'll recognize it. You just have to memorize your RAO, your ventriculogram profile. You've seen the right coronary artery feeds into the inferior wall, and the LAD feeds into that anterior aspect. The LAO, aortogram end to end view, you know the right coronary forms that C shape. The LAO caudal, the spider, remember the spider view, LAO caudal, you're looking at the heart from the patient's feet on the patient's left-hand side, and it gives you an upside-down image of the heart. When you see a model, you'll understand. And that LAO cranial view that I showed you, the vessels are mostly bunched to the right-hand side, but that's just my interpretation, and it's not always exact, but they'll help you remember. Your right coronary artery, just a quick review. The LAO gives you the C shape, you're looking at the heart end to end. The LAO cranial separates the PDA and the PTL, remember the bifurcation, spreads them out. And the RAO is that ventriculogram profile with the PDA and the posterolateral overlapping as you see the heart in profile in that inferior aspect. I'm comfortable with what I've shown you and how I've explained it, although there is a lot. There is just so much. And this is the second last slide repeated to emphasize that LAO cranial movement versus that RAO cranial movement and how cranial angulations display the LAD prominently. So I'll leave this lecture here, and I encourage you to have a look at different pictures and read up on this, particularly the two references I've given you on Kern, which is a very good explanation of how to understand the 3D imaging of the coronary arteries, and also the reference by Grossman, I think is number 8 in your reading list. And with that, I'll end this lecture.